Bismillah ar-Rahman ar-Rahim. To start with, I would like to thank my dearest Professor Mona Salem and my dearest Professor Mona Mamdouh for inviting me to share in this wonderful workshop in the celebration of World Diabetes Day. والحقيقة for the marvelous organization of this workshop. I have the honor to introduce Professor Fiona Campbell, a consultant pediatric diabetologist, leads the Children's Hospital, Leeds, United Kingdom. She is the Associate Medical Director at Leeds Teaching Hospitals, National Health Service, Trust responsible for children and young people's services, and the trust-wide clinical lead for transition. His presentation will be about review of clinical evidence of flash glucose monitoring technology in pediatric population. Okay.
Hello everyone, I'm delighted to be able to present to you today and thank Abbott very much for the kind invitation to take part in the Hand in Hand for a Better Future Pediatric Symposium. I have the following disclosures to make. So I wanted to start the talk with you today about just reminding us about glycemic control in diabetes, and particularly in children who live a very long life with this condition. The importance for us is to improve our glucose levels whilst we avoid hypoglycemia and we limit glucose variability. If we can do all of these things, we will undoubtedly improve clinical outcome and quality of life. Something that we're spending much more time in clinical practice discussing is time in range. And we are trying very hard to get our young people to have their glucose in the time in range between 70 and 180 milligrams per deciliter for as much of the time as possible. HbA1c is a parameter that you'll all be familiar with, and indeed the one that we used almost exclusively in clinical practice to assess whether a young person was at risk of developing complications. But we feel now that this parameter has served us well, as it correlates with our average glucose levels, it predicts future complications and is a good risk marker. It is easy to measure it and understand, at least for the professionals, and we use it in target setting and peer review of services. However, we do feel that really it's maybe time to move on. So let's look at hypoglycemia first. It's really the biggest fear factor for both professionals and parents and families living with diabetes. And you can see in this slide the effects of hypoglycemia, which can range from vascular events and death to brain damage and death. So while HbA1c predicts future diabetes complications, this measure does not assess hypoglycemic exposure, as you know, and as I've demonstrated, this is associated with very adverse clinical outcomes. It can be unreliable in some subgroups of patients, and this may lead to inappropriate clinical management. So we feel that the additional markers are needed in the management of our individuals living with diabetes. And I know you're very familiar with this, but I just thought I would put the positioning of time in range in glycemic management up on the screen to share with you and show that in clinical practice we are aiming for a time in range of greater than 70%, with high glucose values out of range less than 30%, and for our low ranges to be less than 5%. This has been validated in a paper that I've quoted here for you to reference, and it is increasingly being used as a measurement in research. So conclusion 2 is that while HbA1c has served us very well, it has limitations that we need to acknowledge. And when assessing glycemic control, time in range may be a better marker than HbA1c, as it incorporates other clinically important glycemic measures. And hypoglycemic exposure should be minimized, particularly in older individuals and very young individuals, where glycemic variability should always be kept in check. So a little bit about my own service. This is our clinical approach to managing type 1 diabetes. It's about the management in partnership with our patients and families and our parents, and we're very flexible in our approach to what we're advising families, but we're quite dogmatic about the outcomes we wish to see. And to do this, we need a very cohesive team that has unanimity of purpose, excellent communication, and is prepared to support the families at all times. There are specific challenges of paediatric diabetes care, and sustained continuous monitoring is one of them. Glucose targets are not being met by far and away the majority of patients, both in the US and in the UK and elsewhere worldwide. And within this age group, there is a strong relationship with lower A1C and much more frequent blood glucose monitoring, which, as we know, is problematic in young children and one of the things they least like about having diabetes. And we know that we must frequently test blood glucose in the very young patients, especially because they have the greatest glucose variability. And there are specific challenges of diabetes care in teenagers and young adults. And we're all aware of the marked deterioration in concordance with treatment advice at this age. There's increased incidence to the loss of follow-up in our patients in clinic, and we unfortunately see an increase in the rates of emergency admissions. We can refer to this transition as a lost tribe of individuals who we lose after they leave our paediatric clinics, only to turn up in the adult clinics when they actually have the complications of this condition. And their disengagement with our services leads to poor control and increases their risk of long-term complications. Unfortunately, too, even though they are offered the opportunity to use diabetes-related technologies, very often they reject to do so at this vulnerable age. So let's turn to best in class. Now, we all want to be best in class, and currently our Swedish colleagues manage to be best in class worldwide. They have excellent HbA1c outcomes, but they also have a high use of technology. And I wanted to show you this slide to show that in the green, the red and the blue columns, you can see the percentage of a continuous glucose monitor users in Sweden between 2016 and 2018. In the blue columns, you can see the English and Welsh use of continuous glucose monitoring, and you can see that it's more frequently used, up to 35% in the youngest age group, but infrequently used as our cohort get older. And I firmly believe that with the increasing use of technology, especially continuous glucose monitoring, we can improve our outcomes and improve how young people behave in relation to the diabetes. Here is my own figures from our latest National Pediatric Diabetes Audit data from 2020 to 21. And this shows over the years from 2015-16 through to 2020-21 that I have decreasing use of insulin injections and increasing use of insulin pump therapy in my clinic of just over 500 young people aged between 0 years and 20 years of age. And this is the percentage of children in my practice that have type 1 diabetes and that they're meeting the various HbA1c targets. And you can see 43% of my cohort up to March 2021 were reaching less than 58 millimoles per mole, or 7.5%. And this is pretty good, I think, particularly that this was the care that they received over the pandemic months when we were supporting our families entirely at home without face-to-face contact. And it shows the use of being able to download data to give good clinical advice. And this is another representation of this too, showing that the percentage of the cohort having A1Cs below 58 and 48 millimoles per litre is gradually increasing year on year. And I feel this coincides with the increasing use of glucose monitoring in practice. So you'll all be familiar with this hypoglycemia word again. And it is the greatest fear of children and young people living with diabetes and their families, the carers and the professionals too. And this is just a lovely picture of this young boy fighting the dragon of type 1 diabetes. And we feel that giving them continuous monitoring in the form of flash can actually make them become relatively fearless about living with diabetes. And here is just an image, a stock image of the flash glucose monitoring system that you will be familiar with and how it's helping us do our jobs caring for young people with diabetes currently. So I would like to go through the case history of the first case. This is a 14-year-old girl who's been diagnosed with type 1 diabetes for 7 months. She was commenced initially on a multi-daily injection regimen with Levemir insulin twice daily and variable dose Novorapid with meals. She was commenced on the flash glucose monitor at diagnosis. And this is an increasingly important thing I believe we should be doing with our young people. So prior to being discharged from hospital to self-manage, she had her glucose monitor fitted and she was taught how to use the monitor prior to being discharged. Her HbA1c value at diagnosis was 70 millimoles per mole, or 8.6%. And in clinic, when I reviewed her last week after her 7 months of living with this condition, I'm happy to say that her HbA1c was now 33 millimoles per mole, or 5.1%. The importance of monitoring has to be stressed to families very early on. And in our team, we talk about sensor-augmented diabetes care. You note that you don't have to have an insulin pump for this. And we talk about sensor-augmented pump care if the patient uses a pump. But in general terms, we're augmenting our diabetes care with the use of glucose sensing. I feel the early use of glucose monitoring is of paramount importance in caring for young people with diabetes. We stress the importance of frequent scanning, at least 10 times daily, as this is where we feel the number of glucose tests are needed to actually guide self-management. We want them to use the values they see and not just record them for our benefit in the clinic. And we certainly want to encourage them to look at their own data on a regular basis and set aside time of a minimum of 10 minutes weekly to analyse what is going on. And this really helps them recognise patterns and gives them confidence as to when to intervene with their management changes. And we treat glucose monitoring as if we were road mapping their diabetes care. Here is an AGP report from the patient in the early days post-diagnosis. And you can see here that there was 14 days of recorded data. The sensor was active much of the time. And an average glucose was being attained of 5.7 millimoles with very little glucose variability. And she was in target 94% of the time, with hypoglycemia at the maximum recommended level of 5%. So this is what we saw when she was first reviewed in the clinic. This was her overall ambulatory glucose profile, and this showed her to be in target virtually all of the time, but did indicate a hypoglycemia risk in the early hours of the morning. And this is important to address with your management recommendations. And here are the daily profiles. And it's important that our young people look at daily profiles to see where they're coming out of range, perhaps because their doses of insulin with meals may be poorly timed or of inadequate dose, and also the hypoglycemia risk, so that we can tailor their baseline overnight insulin to avoid such events taking place. This is a helpful overview that you may not get because you're not using the same software to analyze your data, but we do use the LibreView data analysis, and you can see the frequency of glucose scanning up to 49 to 50 times daily in the early days, having been living with diabetes. And if we move to what's happening now, I saw her last week, as I said, and we can now see that her target range is still 92%, which is excellent. Her hypoglycemia risk is less, at only 2%. And we can see the average glucose at 190 milligrams per deciliter, and her estimated A1C now sitting at 6.2% or 44 millimoles. So she has not lost any ground at all. And as I highlighted earlier, her A1C is vastly improved. But 7 months later, you can now see that her glucose profile is beginning to be slightly higher in the late afternoon and evening. And this gives you the opportunity to have a conversation with this young person and find out what may be happening at lunch, how much in the way of carbs this young person is having, the timing of the insulin in relation to the eating, and the ratio of insulin used to calculate doses. So all of this is adding to our conversation in clinic and making the clinic experience so much more worthwhile. And again, we teach them with their own data, very importantly, teaching people with their own data to analyze their patterns, suggest what they should do about what they see, and give them confidence to make their own decisions. And in this, you can see some peaks arising with the yellow little caps there, and we can specifically analyze those meals and have a discussion to help young people manage their diabetes most satisfactorily. This is just an overview, once again, that you get on the LibreView to show frequency of glucose scanning. And you can see that that's incredibly variable now, with some values being down at only twice a day, in marked contrast to what I showed you previously when she was doing this up to 50 times a day. And that in itself can be another conversation point in clinic about emphasizing the importance of regular scanning and capturing all the data. And you can see from this, from last week again, that there are gaps in the data, especially overnight. And this so happened to be during our school half-term holiday, when she was going to bed far later and getting up much later, and so having prolonged stays in bed asleep and missing the opportunity to capture all her data within the 8-hour memory window. So this was very helpful for us to analyze and give her further advice. And here is an opportunity to compare glucose data between two time windows. You can see this is the May time window compared with the October time window. And again, you can see complete data in May where there were no gaps. And you can see in October the gaps appearing in data overnight, which are just highlighted. And this gives us a lot of information about giving young people more information to self-manage their condition. So this is another case study I wanted to tell you about very briefly. And this is a very challenging case, a young boy that's had his diabetes for 20 months, recently been assessed by our children's mental health services due to him having suspected autism. He was bullied at school, and physically hitting out at other class pupils as a result of this. He didn't want to have diabetes. He was on his multi-daily injection regimen with Levemir once daily in the morning and variable dose Novorapid, and had A1C values between 44 and 46 millimoles, or 6.2 and 6.4%. He became increasingly distressed by insulin pen injections and was not rotating his injection sites well. His insulin was given after meals, and he was reporting symptoms of hypoglycemia, but Mum wasn't entirely convinced, and he very often resisted blood testing. He didn't carb count reliably, and he was sneaking food into his bedroom to eat overnight. Mum was increasingly frightened of overnight hypoglycemia occurring and was very reluctant to give correction doses of insulin in the evenings, resulting in him having high glucose values during the night. He had a trial of flash glucose monitoring, and this was really successful and built Mum's confidence to try and manage his glucose more satisfactorily in the evenings. At 6 months post-diagnosis, his 14-day average glucose was 12.7, so pretty high, and with a standard deviation of 5.9 and a time in range of only 24%. And his A1C had climbed by now to 75 millimoles, or 9%. So we commenced him on a pump, and flash glucose monitoring continued. You can see here that we had prolonged discussions about the best pump and glucose monitor for this young boy. And we decided on the combination because it best suited his needs. We used the Omnipod Dash system as he didn't want a pump that had any tubing. And we continued the use of Freestyle Libre and analysed his data. You can see over the months, his A1C improved from 7.7% down to 7% over the course of time between April and September. The tubeless pump meant he had more freedom and was more discreet. He could shower easily. It had an attractive handset that was easy to use, and it had good visual appeal, which was really, really important to him, and it was easy to teach. The flash glucose monitor also appealed to him, and he enjoyed scanning his glucose and seeing what the numbers were. This is just a comparison of his glucose values, and you can see on the left his average glucose was 10 millimoles with a standard deviation of 4.5, and you can see that he had high glucose values overnight between midnight and roughly 5 in the morning. And you can see the panel on the right-hand side where, with work and with more confidence of the family using scan glucose monitoring, that Mum was able to give him insulin prior to going to bed and was able to bring his glucose into range overnight as a result of seeing the tracing on his glucose monitor. So I just wanted to highlight the value of the system in managing the diabetes in this way. And the last case history from me is a 14-year-old girl who had diabetes for 14 months, and the team were asked to take on her care because she wanted more intensive management from a team interested in diabetes technology. She was using a Libre 1 sensor, and she was having multiple daily injections of Tresiba and Novorapid with her meal. Her A1C was between 48 and 56 millimoles, and she was a very keen exerciser, and she was keen to improve her variation, even though it was particularly satisfactory, I thought, when she came to us first. This is her AGP report in February, and you can see her target range was 63%, with an average glucose of 155 milligrams per deciliter. And her low glucose values were just within limits at around 7%. So she was having a really quite good care, but she wanted to get it better. We had a look at her profile, and you could see that her risk period was in the early hours of the morning around 6, where she had a tendency to be a little bit on the low side. but you could see she was rising in the late evening before going to bed. And this profile gives us information about how to manage and avoid hypoglycemia in the late evening, so that she didn't need to give corrections during the night and then risk having hypoglycemia prior to waking. And this was her profiles of the different days. And very clearly on the 14th, you can see the hypoglycemia overnight. And we made recommendations about how she would use her insulin to avoid this, how she would manage her glucose around exercise to avoid the peaks of glucose during exercise and minimize the risk of hypoglycemia after exercise. And we used the Diascend platform to download her pump information and her glucose information. You can see above, and the green triangles indicate carbohydrate entry into the pump mechanism. And you can see here that she's using temporary basals, increasing or decreasing during the night accordingly. She's putting glucose into her handset. She's putting carbohydrates in as well, and then using the computer within the pump to actually calculate the doses of insulin that she requires. So this shows good technical ability to match glucose scan data, enter it into her pump, and give her the appropriate amount of insulin. And here we just can see a variation on the number of boluses this young lady was given. And she has some days where there are multiple boluses and extended bolusing going on. But you can contrast that with a day on the Sunday, you can see in the bottom right, where she had very infrequent bolusing. And it's always worthy of looking at this just to see what happens on one day versus another, all as part of the education around self-managing diabetes. So in summary, the recipe for success using flash glucose monitoring, I believe, is about being dogmatic about the outcome you wish to achieve with your team, but being very flexible in your approach. Care must be tailored to the individual and the psychosocial needs of the child and their family. You need a highly skilled multidisciplinary team that's trained in children and young people's diabetes care and the use of technologies. And you must strive for optimal control from the outset and for as long as possible. Each team member must have unanimity of purpose, clear and ambitious targets that they set for their patients, and excellent communication skills between the family and the professional team members themselves. And there must be facility for ongoing self-management education, support, and assessment and reassessment. And the teams must be adequately resourced, including access to diabetes technologies for all, no matter where they come from and where they live. Thank you very much for your attention, and I do hope this presentation